Within and across components of a multi-team system, communication is critical to the effectiveness of a team and to ensuring patient safety. TeamSTEPPS provides several communication strategies that can be used to ensure effective communication. The first technique is SBAR, S-B-A-R. SBAR provides a standardized framework for members of the healthcare team to communicate about a patient's condition. You may also refer to this as the I-SBAR, where I stands for introductions. SBAR is an easy-to-remember tool that is useful for framing any conversation, often a critical one requiring a clinician's immediate attention and action. In phrasing a conversation with another member of the team, consider presenting the following. Situation, which is what is happening with the patient. Background, what is the clinical background? Assessment, what do I think the problem is? And recommendation, what would I recommend? Let's look at a short video clip in which the SBAR technique is used in the hospital, and then I'll describe an EMS situation where SBAR could be helpful.
Hi, Dr. Feldman? Yes, this is Amy from 2 West. I've been taking care of Miss Everett. Well, she's an 82-year-old woman. She was admitted 3 days ago with DVT. She's on heparin, telemetry, and oxygen. She's been alert and pleasant with no problems other than urinary retention. Okay, she has a Foley in place. But tonight she appeared confused. She's awake and oriented to person, but she thinks that she's at her aunt's house and that Ronald Reagan is president. Yeah, well, no, I checked with her nurse from the last few nights and confirmed that she doesn't sundown and she's normally very sharp. Her heart rate has increased to 110. Her blood pressure is down to 110/60. Yeah, her systolic usually runs 150. Yes. Her temperature is 37 Celsius. She looks pale but not uncomfortable. Her coag studies are within the parameters and her blood gas is normal. All other AM labs are normal. She's not putting out much urine and it looks cloudy to me. I'm worried about her. I think she needs to be seen. Want me to order some labs? Maybe send her urine for culture?
Yes, sounds like she could be getting septic. Send a urinalysis with culture, chemistries, and a CBC. Thanks for calling. I'm on my way, but I need to know if there are any changes immediately.
Here's an example of an EMS scenario that SBAR would be useful. As I go through this, think about the steps to SBAR: the situation, background, assessment, and recommendation. So you and your partner make a run to a well-known patient that usually calls for chest pain. Your partner is new to your agency and doesn't know the patient. Your partner is the team leader and you are the team member. The patient calls frequently for chest pain. You treat him appropriately and take him to the hospital. The hospital runs a variety of diagnostic tests, can't find anything wrong, and sends him home. This day is different, however. The patient calls for chest pain, except you notice something is different. On the way to the scene, you mention that you make a couple of runs to this patient weekly. As you and your partner begin treating the patient, you hear your partner saying to the patient that he doesn't really need to go to the hospital because every time he is transported, the hospital can't find anything wrong and sends him home. However, you've noticed something different on this day. You notice the patient is having more difficulty breathing than normal, and he is slightly sweaty. He doesn't usually present in this manner. As the patient is about to agree with your partner and not be transported, you ask your partner to talk away from the patient. So you might say, the patient is presenting different than normal. I think he is really sick. This is your situation. Your background would be that you would tell your partner, in the past, when he had chest pain, he didn't seem to have any difficulty breathing and he wasn't sweaty. Your assessment might be, I'm concerned that he is having difficulty breathing and is sweaty. And then for your recommendation, you tell your partner, I think he should be transported to the emergency department for evaluation. Another communication tool is the call out. A call out is a tactic used to communicate critical information during an emergent event. Critical information called out in these situations helps the team anticipate and prepare for vital next steps in patient care. It also benefits a recorder when present during a code or emergent event. One important aspect of a call out is directing the information to a specific individual. An EMS example would be if the paramedic was working on a critical trauma patient with a blood pressure of 104/72. While the paramedic was busy starting an IV, you notice the blood pressure has decreased to 90/60. So you call out to the paramedic, the blood pressure is down to 90/60. Another example would be that if this trauma patient were intubated and you were ventilating and the paramedic asked, how is lung compliance? You would call out the answer. A check back is when you are given an instruction by the team leader and you repeat it back to them to make sure you understood the order. If you have a patient you think is having an anaphylactic reaction, you may call medical control to get an order for epinephrine. The physician orders 0.25 milligrams of 1 to 1,000 epinephrine IM. You then repeat 0.25 milligrams of 1 to 1,000 epinephrine IM. The physician would either confirm or change the order. This does two things. It makes sure you heard the order correctly. It also makes the team leader think about what they ordered. If they gave you an incorrect order, they can change it before the incorrect medication or dosage reaches the patient. When a team member is temporarily or permanently relieved of duty, there is a risk that necessary information about the patient might not be communicated. The handoff strategy is designed to enhance information exchange at critical times such as transitions in care. More importantly, it maintains continuity of care despite changing caregivers. A proper handoff includes the following: transfer of responsibility and accountability. When handing off, it is your responsibility to know that the person who must accept responsibility is aware of assuming responsibility. Similarly, you are accountable until both parties are aware of the transfer of responsibility. Clarity of information. When uncertainty exists, it is your responsibility to clear up all ambiguity of responsibility before the transfer is completed. Verbal communication of information. You cannot assume that the person obtaining responsibility will read or understand written or nonverbal communications. Acknowledgement by the receiver. Until it is acknowledged that the handoff is understood and accepted, you cannot relinquish your responsibility. Opportunity to review. Handoffs are a good time to review and have a new pair of eyes evaluate the situation for both safety and quality. Additionally, handoffs include the transfer of knowledge and information about the degree of certainty and uncertainty regarding a patient, for example, whether a diagnosis has been confirmed, the patient's response to treatment, recent changes in condition and circumstances, and the plan of care, including contingencies. It is important to highlight that both authority and responsibility are transferred in a handoff. As identified in root cause analyses of sentinel events and poor outcomes, lack of clarity about who is responsible for care and decision making has often been a major contributor to medical error. Each facility or agency should determine a standard protocol for delivering handoffs and make the protocol known to staff. I Pass the Baton provides one option for conducting structured handoffs. I is for introduction. Introduce yourself and your role or job, and include the patient name and the patient. Patient, their name, identifiers, age, sex, and location. Assessment, presenting chief complaint, vital signs, symptoms, and diagnosis. Situation. Current status and circumstances, including code status, level of uncertainty, recent changes, response to treatment. Safety concerns. Any critical lab values, reports, socioeconomic factors, allergies, alerts, falls, isolation, etc. Then the word the, and then baton. B is background for comorbidities, previous episodes, current medications, family history. Actions. What actions were taken or are required? Provide a brief rationale. Timing. Level of urgency and explicit timing and prioritization of actions. Ownership. Who is responsible? Include patient and family responsibilities. And last is next. What will happen next? Anticipated changes, what is the plan, and are there contingency plans?